So we'll get started. Good afternoon, everyone, and thank you for joining us. I'm Amanda Nelson, Long-Term Services and Supports Manager with the Office of Aging and Disability Services. Today, in addition to our presenters, I'm also joined by our colleagues at DHHS, the Maine Healthcare Association, and Maine's Long-Term Care Ombudsman Program, who have joined forces to support nursing facilities through quality improvement initiatives known as QuEST. Quality, excellence, staffing, and teamwork. As part of the new nursing facility reimbursement system, Maine nursing homes have an opportunity to earn a share of an $8.1 million quality bonus pool through a new value-based payment program made possible through the Nursing Facility Transition Fund. In 2025, that payment is based on participation in quality improvement initiatives rather than on the performance in the selected measures. Today's QuEST call does count towards your facility's 2025 participation requirements. In case you missed it or need more information, please email oads.ifquality@maine.gov. And if you're not already muted, if you could mute your lines, please, unless you're trying to talk. As a new feature, we are offering certificates of attendance for licensed administrators attending this call upon request. If you would like a certificate of attendance for this call and you're a licensed administrator, please email us at oads.nfquality@maine.gov. Please only submit a request if you are a licensed administrator and you attended the entire call. There won't be any partial credit issued for those. You may also request a copy of today's chat log. So we are excited to have you all today. Again, just to make sure that you get credit for yourself and your facility, make sure that you drop your name and the facility that you represent into the chat. We need to know who you are so that we can make sure that you get credit. This meeting is being recorded. The recording as well as the slides will be posted to our rate system reform website, which Karen will drop into the chat in case you don't already have it. The materials will also be added to the SharePoint site, which will be distributed to QuEST members via email. If you're not already receiving those updates, please send a message to our inbox. Our goal is to share information, but of course, most importantly, to hear from you, our local experts, on some of the best practices that you're implementing. So first up today, we will hear from our, not first up, I apologize. First up, we'll hear from Olivia Alford, followed by our national PBJ experts, Nate Horde and Jolene Johnson. And then following that, we will have plenty of time left at the end for discussion. So as you know, nursing staff turnover is one of the selected value-based purchasing measures. Nothing will sink your turnover score faster than a failed PBJ audit. So we are grateful to have our national presenters here to give us a little bit more insight. But like I said, first up, we have Olivia Alford joining us from the Office of Maine Care Services with a brief update on Maine's value-based purchasing initiative. Olivia.
Great. Thank you, Amanda. She's such a great leader of this work. I'm from the Office of Maine Care Services, as Amanda said, and I'm here just to provide a brief update on some of the conversations we had a few months ago regarding, let me try to get this out of here. Just get it here. There we go. Is that the right view, Amanda?
Yep, we got you.
Okay. Regarding specifically some of the feedback that you all shared with us late May regarding one of performance metrics, which we're not talking about in detail today, but again, just to close the loop on a conversation we had in late May about the QuEST resident and family satisfaction survey. So if you all remember, for those who attended in late May, we had a really good conversation, both from the developers of the QuEST resident experience survey, but also how it looks to implement that survey in the nursing facility setting, and some of the thoughts that DHHS had about what that requirement might look like within the value-based purchasing arrangement with you all for the quality bonus pool and performance-based payment. And you all gave some great feedback about some of the areas where you thought that maybe the plans should be tweaked from what the requirements were. And we had conversation about who's eligible for the survey, how many surveys do we need in response, how can we administer the survey. And so what I put on the slide here is just to remind you of some of the points where we had some strong feedback from both the nursing facilities and the Maine Healthcare Association and others. And then we'll go through each item that has shifted in plans for what we're thinking now, based on your feedback and what we've changed for how we think CoreQ will be administered for calendar year 2026 and 27 and beyond. So hopefully these are all things that you all will appreciate, as they're entirely based on your feedback. So originally we had thought that we would require both resident and family surveys, and that hasn't changed. So just as you're thinking about contracting with these vendors, we're still going to be requiring resident and family surveys. So no change there. We originally discussed that we're going to lean towards only having male surveys were accepted to be scored. The feedback was thinking that maybe we should expand that, allow different types of surveys to be administered, and we agree. So we're changing it, and now we will allow the method of delivery to be by mail, text, or email. So we're going to put forward that requirement for your CoreQ implementation. Should provide you a little bit more flexibility about how you get those surveys back, and hopefully make them easier to get responses and more responses and better quality of response. We have talked back and forth about the importance of understanding the CoreQ survey itself, and also the specifications from the developers about how they envision and have studied the survey to be administered. So we are generally following the standard CoreQ measure specifications that are documented, and maybe that document's already on SharePoint, but if not, we can make sure it's up there. But we are going to make one modification here in Maine. We are going to allow members that are at a hospice level of care to complete the survey. So if you look at the national literature and the specifications, it'll say to exclude that population. But we know that some facilities will have members in that group, and that you will want to receive their feedback, and that will help you get the number of required surveys. And again, we just want to know the experience of those residents and or their family members. So we will permit those residents to be part of your sample. We also had a lot of discussion in this group, and this happens in every state that does this, about the challenge with getting the required minimum number of surveys back for each facility. So we discussed the requirement for having 20 surveys received for each group. So 20 surveys from residents and 20 surveys from the family caregiver perspective, and that those 20 surveys had to represent a 30% response rate. That's the standard nationally. We're going to go into the next slide to get a little bit more detailed about some things we've thought about that would make this maybe work better for small facilities in Maine. And Amanda, I can't see it. Yeah, go ahead.
One more thing, Olivia, before you move on to the next slide. Your slides are in presenter mode for some reason, so it's showing the next slide. I don't know if that's something that can be adjusted or not. Thank you, folks, for
At the top of your screen, Olivia, if you'll click on the display settings and you'll just switch it to where it's doing the big picture. Yeah, click on that button and just hit swap and it'll be perfect.
Okay, you guys are now seeing the right thing. Yeah, that's what I was wondering.
I don't think you clicked on it.
It swapped it on mine. Okay.
There you
there
go.
we go. Oh, just a delay. Thank you.
Great. So I don't know what slide you were looking at.
We're good.
Okay. All right, now we're just catching up on the chat because I couldn't see the chat before, but I'm going to go over to that.
There's
so
some. Oh, go ahead, Olivia. Sorry.
Yeah, so I do see the feedback about the phone, us specifically not permitting phone response. And, the reason for that is really about the social desirability bias that comes with phone surveying, where you're really looking to, there's research that shows that people tend to give higher marks when they're speaking to someone, and hard to give a more honest or potentially negative or just critical in any way response when talking on the phone. That said, there will still be rulemaking and opportunity to give more public comment on this front. So I think encourage you to submit those comments later on. At this point, this is where we're starting from, or this is where we've moved to, I should say, regarding how to get the most meaningful quality assessment of the facility. And I know, and so we can go into the next comments, which are talking about the number of residents, the number of surveys that are needed. Okay, so speaking of trying to get the 20 surveys for each group and the return rate, where we've moved to in thinking about how to create some flexibility for Maine is that for facilities that don't even have 30 eligible residents or 30 eligible families in the first place, those facilities will essentially be able to, if they choose to, not have to get the 20 surveys in response. So those facilities with that smaller number of eligible populations still would have to do the survey. They would still have to do the survey and they still have to get a 30% response rate. But if that 30% response rate doesn't get you to 20 surveys, which it wouldn't, then you won't be penalized. There will be no negative thing taken away from your ability to access the performance-based payments because of the limited number of eligible populations you have. Because again, you're still completing the survey, you're still doing the exercise, you're not resulting that with 20 surveys in hand afterwards for each group. So that was something that we've landed on, working with the developer, working with counterparts in New Jersey and how they have implemented this model and thinking about the ways that we could still incentivize the use of this survey tool to get the feedback, regardless of the number of surveys completed. It's always helpful feedback from a quality improvement perspective. So still getting the feedback, but really not able to score those facilities that don't have the 20 completed surveys. So not penalizing the facilities for when that is the case. But as we'll talk about in a little bit, it'll still be in the nursing facility's best interest to reach the 20 eligible surveys. There is a benefit to completing the 20 eligible surveys, received surveys, but there will be a penalty if that doesn't happen for these small facilities. One of the reasons why we're keeping this brief today, well, I'm going to go through one more slide and then I'll tell you why this gets a little bit complicated. But just for some other minor clarifications that we talked about in May, it is true that state guardians who are regularly involved in the resident's life can be included in these surveys as on the family caregiver side, or the family side. So just clarification that is permitted. And then when we're talking about the scoring of these surveys, we will use the national AHCA database for getting the benchmarks as far as what's the minimum quality level of response, and then what's the high achiever. So what's what is the 20th percentile nationally for survey responses scored, and then what's the median for the high achievers. So you'll be scored against national peers, essentially, is what I'm saying. So some of the things to keep in mind is there is a lot of detail behind the methodology that will make more sense when we have more time to go through examples of how different scores will generate different payments in calendar year 2026 and 2027. Part of that gets into what I was just talking about, is where you won't get penalized for having missing surveys, but there will be benefits to having your data scored as far as how it impacts withholds and quality bonus pool and all those things. We don't have time to go through the full methodology of these things today. There was an initial presentation, if you recall, probably back in fall last year, regarding this whole rate reform effort that went through all the different components, and there was detailed public comments. We're going to hold a separate webinar later this fall to walk through the value-based purchasing calculation specifically in more detail, so that you can really see how the math works and how the scores feed into dollar amounts. It's too much to cover in the amount of time we have today, but we'll go through that and we'll use specific examples of a small facility, medium facility to get to some of these core Q issues. And then a low performer and a high performer to help you understand how these things will be scored. We wanted to provide you information today that would help you progress on getting a core Q contracted vendor, so you know what types of surveys that will need to be collected, and then again that we're doing both populations for data collection. Another important reminder, announcement, I guess, regarding all of this is that we are getting a little bit late into 2025. We still plan to have rulemaking that will memorialize these conversations and these decisions so that there's a main care benefits manual rule covering these topics. But that rule is still going to be published in the next couple of weeks or months. We, however, won't be on schedule to implement the withholds of your routine and direct care rates on January 1, 2026. So there will be a delay in the withhold component of the value-based purchasing provisions. Again, you may not have been tracking that this was coming, or maybe you were, but originally we had planned to start withholding 1% of nursing facilities' routine and direct care rates beginning on January 1, 2026, to ensure that there was minimum performance met on the 3 quality measures. So that's the portion that's going to be delayed, and we'll tell you the new timeline as the rulemaking timeline progresses about when to expect the withholds to kick in. So as of now, we're still just working under the schedule of getting your quarterly scorecards, next one coming out in early October. You'll have this webinar later this fall to kind of walk through, again, the calculations and the math surrounding performance-based payments as we enter into 2026 and 2027. And that's really where we will be. And you can continue to focus on performance on those 2 measures that you've been receiving data on, and you can continue your efforts to secure a core Q vendor for doing the surveys in 2026. And yeah, go ahead, Amanda.
I was just going to say, another question came in. Does the department have a list of core Q vendors for reference?
We do not have a list. We're certainly not giving preferential treatment to any vendor, I'll say that. Amanda, after the last call, I know there was discussion about the different facilities sharing who they work with. And that happened a little bit live during the call, but did we end up collecting that information in any way?
We have what was available in a chat log. I could share the chat log from Core Q with folks. I don't remember how much is in there. A couple references. If anybody has a vendor that they really like that they're using right now, you're welcome to put it in the chat now.
And then the national site, there's a list nationally, I believe as well, Amanda, right, for Core Q vendors, but it might be a little outdated. We've heard that list isn't the most reliable list. Is that right, Amanda?
That's right. So on the Core Q site, I think it's just coreq.org. It's very simple website.
Hi, Amanda.
There is a list, but it is outdated. And I think Maine Healthcare Association is beginning to vet some of those vendors too. So Mo?
Yeah, just to let you know that we do have a list of vendors that have been working in Maine, and we'll get that together. We'll put out some information for people. I know many people have called us. We've had many vendors reach out. Many of our nursing homes are also members of our GPO, and so we'll be talking with some of our people who are GPO, and we can work to see if we can get some better pricing for people who want to do that. Lastly, I just want to let everyone know that, and maybe Olivia or Amanda, maybe this isn't the time to discuss the data being uploaded into long-term care trend tracker. But if we're gonna, at some point, we do need to have some discussions. If you want ACA to upload your data, then we're gonna need to have some kind of agreement, and we'll be working with all of our members on this to be able to do that.
Yeah, thanks, Mo. We should connect offline. We do, that is a good point. We will want facilities to submit their data to the national database, to, again, it'll be just pooled with everything else as far as creating the benchmarks, but we will want to do that. And then we understand that we'll be able to, and access the high level information back from each facility regarding the number of surveys that were completed. We may need to ask for supplemental information when it comes to things like response rates, or those smaller facilities who don't meet the eligible population will have forms and such to make sure that anyone who is seeking to qualify for that exemption, that we can get that information from you. But yes, let's connect more about that. Another thing I wanted to put on the slide, but I just realized now I did not put on the slide, was, we at the department will not be looking at or have access to individual survey responses. So we are not seeking to or sharing information. We don't even have the information about what an individual survey response about your facility said. So it won't be used for purposes within the department for licensing or whatnot. It's just not even available to us, that those what an individual or family said about your facility. So this is really about quality improvement. It's your data, but the what's submitted nationally and what's used for scoring is just really, how many were completed, of how many were sent, what was the average score, like those kinds of metrics. And we can share more information if that's helpful for you all to know what is the department seeing, and what are we not seeing, so what's within our view and what's not.
Just want to pause and see if there's any more questions for Olivia with VBP updates, CoreQ or other. Whereas a month falls between each of these QuEST calls, just by nature of the initiative, you're always welcome to submit questions to the inbox too. And those do get distributed among the team. And a lot of times the things that we cover on these calls are generated by the questions that you all ask in the inbox. So we love to get those from you all, so don't hesitate. Thanks so much, Olivia. So with us today, we have Jolene Johnson. Jolene is the president of Luminate Healthcare Consulting. She is a nationally recognized expert in PBJ compliance and staffing strategy with over 28 years of healthcare experience. She's led national trainings, developed audit-ready processes, and helped facilities all over the country strengthen their staffing data. Also joining us is Nate Horde, Simple's senior PBJ strategist. He's been with the Simple team for over 14 years, supporting thousands of users and nursing homes in a number of ways. He leads the Simple PBJ product team and serves the nursing home industry with PBJ educational webinars like this one. Ladies and gentlemen, we're honored to welcome today's presenters, Jolene Johnson and Nate Horde.
Thanks, Amanda. I'm going to share my screen. So just give me just a second. Hi, everyone. A lot of you guys may have already met us on the Simple training. So, if I've met you before, hi. And if I haven't met you, it's very nice meeting you. Let me go ahead and share my screen. Okay. Oops.
Looks like the wrong screen, Jolene.
Yeah, it is. I noticed that. Just give me just 1 second.
Been there. There we go. Yep, you've got the learning objectives up.
All right. Perfect. All right, guys. So nice being here with you folks from Maine. Today we're just going to go through some PBJ information. My learning objectives today is I'm going to go over a little bit of the basics. And then once I go over some of the basics, then we're going to dive into turnover, explain how CMS calculates the staffing turnover. We're also going to go through the CMS PBJ audits. So in order for me to do a good job on how to prepare you for an audit, that's why I'm going to go over some of these basic things, because whether you pass or fail is if we do the basic things right. So some of this stuff, if you've attended some of our other trainings, is going to be repeat, but for the folks on the call that doesn't have some of that foundation, I really want to give that to them so that they can succeed in their PBJ process that we've been given by CMS to submit this information. All right, so the number one thing that you really need to do in order to not fail in your PBJ and your turnover is to submit your data timely. If you miss the deadline, there is no submitting it after the deadline, which would mean that you would have a 90-day gap for all of your employees, which would show 100% turnover. Okay, so the most important thing that you can do is to submit your data timely so that you don't have 100% turnover because you didn't submit your data. So as CMS physical quarters go, October 1st through December 31st is Q1. The due date is February 14th. It's posted to Nursing Home Compare on the fourth Wednesday in April. The data that we just submitted was due on August 14th. That will come out on in October on the fourth Wednesday. So it's basically 45 days from the last day of the quarter. That's why you have one due date that is on the 15th versus the 14th. Guys, a lot of folks miss the due dates because they think our data is due on the 15th every time. It's not. It's only due on the 15th one time, and that's May 15th. And that's because February has a short month. So I really want to make sure that everybody knows that. It's 45 days from the close of the quarter. And so you have February 14th as a due date, May 15th, August 14th, and our next due date is November 14th. Okay? And then we're going to go into PBJ data submission and best practices. And this is going to also help you with your turnover. It's going to also help you with passing your Myers and Stouffer's audits. And we're going to get into those audits as well. So I like to start with the biggest mistakes. That way, when I'm talking about these other things, that you can kind of see where these mistakes could happen. So I'm going to start there, not removing meal breaks for all employees. Just remember that it is required that we remove a meal break every 8 hours. So if an employee works exactly 8 hours, we can only submit to CMS 7.5 hours. Whether we pay them through that meal break or not, we're required to do a 30-minute meal break. So then when they get to the 16 hours, then all we can report is 15 hours. And if they do a 24-hour shift, the most that we could report is 22.5 hours. You know, we're not really allowed to do that, but that would be the case if there was an emergency and we had to do that. I have seen it in South Carolina with the flooding where they had nurses working 24-hour shifts. I also saw it in California with the fires. In those situations, the state makes exceptions because we have to make sure that our patients are getting what they need. But just know if you do have an emergency like that, we can only claim 22.5 hours, whether we paid the folks for 24 hours or not. And then submitting overnight hours by shift start or end date. So just remember that how most folks pay through payroll is the day that you clock in is the day that you get paid for all of your hours. But for PBJ purposes, that is not the case. That changes at midnight. So if someone clocks in at 11 o'clock today, p.m., then 1 hour would be on today, and the remainder of the shift would be on the following day. And of course, we would have to have a meal break for the whole shift if they worked 8 hours or more, or whatever your policy states. So if your policy states, and Myers and Stouffer's will ask for your policy, that we require a meal break after 5 hours or 6 hours, then you're going to need a meal break at 5 hours or 6 hours. That's more stringent than the federal requirements, but if your policy states that, they're going to follow that when auditing you. So I always recommend not having a policy that's more stringent than what CMS requires. That way you're not opening yourself up for failing an audit based on something that you didn't have to do in the first place. Okay? And then underestimating the importance of census and acuity. Just remember that your census is important to make sure that it's accurate. Everybody has different electronic medical records, but I'm going to use PCC when I'm talking just because that's, has the biggest market share and it's just easy for me. So if your census in PCC says 70 people are in your facility, but your MDS census shows, more than that, then you're looking at possibly failing your audit because your census is part of that error rate. The acuity, I can look across the country at the weekend staffing and, sorry, my coffee maker decided to clean itself. So with that, and I don't even drink coffee. But with that being said, your acuity is based on your nursing PDPM CMI. And so if you're in a CMI state, your staffing you're going to have more staffing in order to meet those star ratings that you want. Whereas like in a state that I live in Arkansas, we don't have CMI. And so our weekend staffing is like 3.4, whereas Ohio or Indiana and some of those, it's at 2.5. They're actually staffing the same as we are. It's just that they're focusing on that case mix. And so it looks like they're really not, but they are. So just know that acuity has a major impact on your star rating and making sure that that's accurate. And then not auditing your data before you submit. So just make sure these payroll systems have glitches. Sometimes we don't get everything sent to us by agency. Just make sure that you're doing a thorough audit of your data and that it's accurate. And I'm going to go into some of the areas that Myers and Stoffers looks at. And I look at that with 100% of my clients. Anybody that works more than 80 hours in a work week, they're at risk for being pulled. I've only had 1 or 2 audits where they didn't pull the DON. So I always audit every single time the DON's hours. And then making sure that when you're looking at your information and auditing it, that you're not just auditing it for data integrity, but what picture is your data painting to CMS? If your DON goes to Thailand for 2 weeks or whatever, who is sitting in as your DON, interim DON? Because the requirements are that we have a DON if we have a census of 60 or greater, right? So when surveyors pull their CASPER reports, they're going to be looking at if you met that requirement. So make sure that if you have your DONs out for an extended period of time, that you are coding someone else to that DON position that you're leaving in charge. So we don't ever just leave for 2 weeks and no one's manning the nursing department. So whoever's manning the nursing department, it's most likely going to be your ADON. You would want to change that ADON from a 6 to a 5. Okay? And then waiting till the last minute to submit, that's always a big problem. If you have connection issues with CMS and it doesn't go through and you wait till that last day, there's a high likelihood that they may not be able to correct that and you would not be able to get that data in, and they will not accept for any reason late data because they give us 45 days. Okay? Now I'm going to stop there for just a second and see if there's anything in the chat as far as questions, or if anybody has any questions, I'll be more than happy to answer those.
And Jolene, just let me know whenever you're ready for either of the poll questions too.
Yes, yeah, you can go ahead and give the first poll question.
Okay, we've got the first poll question up. If you could please put in your responses. Thank you. Lots of responses. Keep this open for just about 1 more minute.
Yeah.
Okay, 10 more seconds if you can get your responses in if you haven't yet. Oh, that's a good question. So what constitutes a failed PBJ audit? We had one, but haven't heard anything back. Is that common, Jolene?
Well, it's common for you not to hear anything back because one of the requirements of the Myers and Stoffers and of CMS is that you go in and get your result letter out of the portal. So the last tab in the portal is your letter stating whether you failed or passed. So if you haven't gone into the portal, you may not know the results. Now, some of the auditors will send an email, and that's how some folks get their results, but that is not a requirement for them. And I have a lot of auditors that do not send the results out. So I recommend that you go into the portal twice a week until you get the results, because you only have 7 days for your appeal. And if you only go in, if you go in Monday morning at 8 o'clock in the morning and look, and they put it in at 4 o'clock on Monday, and you don't look again till Monday, and that means you're only going to have 3 or 4 hours to put together an appeal. So I highly recommend at least 2 days a week that you're looking, so that you at least have 2 or 3 days to respond if you disagree with the findings.
And in the chat, somebody asked which portal? What portal?
It's the Myers and Stoffers portal, and we're going to go into that when we get to the Myers and Stoffers audit, so that I can show you what all of that looks like. So if you don't know what the portal looks like, then you haven't had an audit, and I will go into some of that part a little bit more later on in the training. Okay? And you're going to be able to see what it looks like. I have screenshots and things like that. Okay? All right, so 23% have passed, and we've had only 7% that didn't pass, and 35% have not had an audit, and then 34% of the folks on the call are not sure if you've had an audit or whether you passed or not. So that gives us, some room. The 23%, good job. The 7%, I'm sure you've learned all about it and you know how to pass now, and you could probably do this training for me. So we'll work through the rest of the PowerPoint and go from there. Now, Amanda, I didn't send over the questions for this webinar. Nate did. So if you see the other question, if you see a good place for us to put it in, just pause and let me know, okay?
Yeah, that sounds great. And the other one is about the audit process. What kind of audit process each of us has in place if we've got that locked down or not quite. So.
Okay, so I'm going to go ahead and let you do that, because we're going to get into the do's and don'ts, and that will help me be able to guide the conversation from here forward. So go ahead and do that poll.
Perfect. Oh, and I apologize. It's the PBJ submission process.
Okay.
Okay, so we've got another polling question up. How would you say your current PBJ process measures up? Lots of responses rolling in.
Jolene, also in the chat, looks like there's a couple of questions. How often are the PBJ audits, and what are the consequences of a failed audit? I know you're probably about to dive into some more of that, but maybe we could touch on that real quick while we do our poll here.
Well, the audits are random. They are trying to audit every single facility once a year. Some of them are triggered based on your data. Some of those are just trying to get 25% of the facilities audited every quarter. And part of the reason that they're trying to audit all of the facilities every year is because it has an effect on your survey. So if you fail an audit, then you're automatically going to get an F851, which is a 16-point F tag. It's a minimum of 16 points. And it would be unfair to audit, 10% of the country or 25% of the country, and the other 75% of the country not get audited and not be at risk for that 16-point tag. So to level the playing field, they're attempting to audit all facilities every year. Now, has that been accomplished? No. But that is the goal, to make it a fair playing field so that some people don't take a hit on their survey star rating where others don't because they weren't audited. So you got two facilities in the same county. One gets audited and they go to a 1-star in staffing. They get a 16-point F tag, and the other building doesn't get audited, and their data is worse than the facility that failed it. That's not fair because they're in the same state, in the same county, and their survey would not be fair, if that makes sense. So that's why they're trying to go that route, and make it fair and keep people honest. And it's also going to drive, as you all know, on the national level as well as your state, value-based purchasing. So it wouldn't be fair for one person not to get the 2% incentive payment where another facility did get it, that maybe shouldn't have, because they would have failed as well. So just trying to make everything fair by auditing everyone is what I'm being told. Now, do we have the results for our...
We do. Here we go.
Okay, so which of these best describes your current PBJ process? We invest a good deal of time in collecting and submitting our data and overall feel confident in accuracy. That's great. That's 41%. 15%, we do the best we can, but it's added responsibility to our current duties and we're not really sure if the data is accurate. And then 5%, we do not invest enough resources in our PBJ process, and 38% is just really not sure. So that's where we stand on the levels of support. So I'm going to go into best practices now, do's and don'ts. Do review time entries daily and weekly, just making sure that they're accurate. So what you don't want is for someone to miss a punch and you not get credit for all their time. So just making sure that you're reviewing to make sure that your information's going in. And also in that review, you're going to be looking at, did I have, the required number of RN hours? So federally, we're required to have 8 hours of RN coverage 7 days a week, and that can be covered by your DON. And then enter your agency hours every day versus, doing it at the end of the quarter. If you use Shift Key or Clipboard or some of the folks that do have where you can pull your PBJ data out, make sure, to be pulling that and looking at it and making sure it's accurate. Matching your PBJ data out of Shift Key and those folks to your invoice is imperative. And then also your schedule. I have seen folks getting billed double when they shouldn't have been. I've seen where they had an RN scheduled and then they called them and told them not to come, and they had a minimum of 4 hours in their contract that they would get paid, and that pulled over to PBJ. Well, they weren't in the building, so that couldn't be counted, and that went towards their error rate. And just remember, they don't publish an error rate. I have been told, because I've done hundreds of these Myers and Stoffers audits, and I've been told by 4 or 5 different folks at Myers and Stoffers that the error rate is 3%, but that error rate, they can look at it and make it less if what they found they feel like is a major problem, or they could give you some leniency if it was a data integrity problem that came from your payroll system and there was a glitch. So they do have some leeway in making those decisions, but that the starting point is that 3% is what I'm being told. So just remember that part of it. and I have seen agency be a problem. Verify all hours before payroll runs, upload hours monthly. You know, one of the best practices is by the 20th to avoid last minute errors. And if you're using a prediction tool, you'll be able to predict for the remaining part of the quarter. So one of the things that I do is I upload my data into the system for my customers, and then we look at, are we at the star rating that we want? And what do we need to get there? And what is the cost of that going to be? And how does that, you know, talking with the DON, how does that go with care? If I increase 4 hours of RN, we're going to be able to get you to a 2-star, but do you need 4 hours of RN coverage, or do you need, you know, more LPNs on the floor, or more med aids, or more CNAs? You know, making sure that the clinical also is being looked at while we're making these decisions is always a priority. But you can go in and look and do predictions and start with, what do we feel like we need, and then mapping that. Okay, so that here's the cost of that, here's our census, here's our acuity. Can we afford to be able to do that? And if we can't, do we stop admissions? You know, what does that look like? And being able to do that on a monthly basis. And I highly recommend updating your facility assessment once a month, at least signing off on it. I've seen a lot of facility assessment tags based on staffing, and it had to do with staffing. So just know that all of this is connected, and we need to make sure that we're painting a very clear picture. And then what we don't want to do is wait until the end of the quarter, rely on memory for handwritten logs for agency staff, assume payroll data is always PBJ ready. It is never PBJ ready. You will always find some mistakes. And then miss internal deadlines. It puts your submission at risk. So just know that being proactive, doing it month to month, is going to make it to where it's not so hard for you when you go to submit that quarter. And then I want to get into the pay type codes. And the reason that I'm going over this is one of the questions and answers and clarifications that they just came out with about a month ago. They are looking at Myers and Stauffer's more at the exempt, non-exempt, and contract than they were in the past. And you can fill an audit based on the not being coded accurately. So all of your time could be accurate. Like you got every meal break deduction, you got every midnight split, everything is perfect as far as your time. But if you have people under the wrong pay type, you could still fail an audit. So make sure that you have your exempt, which is your salary people, coded accurately. If someone changes from an hourly to an exempt in the middle of the quarter, making sure that you're changing that timely and that it's reflective accurately in your data that you submit. Your non-exempt is just your hourly folks. I don't see a lot of problems with hourly folks. And then your contract is your agency staff. And your contract, a lot of times I see those folks coded as hourly. Yes, they are hourly for the person that they work for, but for you, they're contract. Okay? That has been the big confusion there. Well, I asked the employee, they're hourly. Yes, they're hourly for them, but they're contract for us. And we have to report it as contract. And just remember, for your contract staff, it has to be audible and verifiable. So that means that you have to have a contract, you have to have your invoice, and you have to have a timesheet for that agency staff. And then you also have to provide Myers and Stauffer's with proof of payment. Okay, so I had a group that failed their audit because they could not show proof of payment because they had not paid for the agency staff. The problem is that they had spent 6 months working on this particular invoice that they were trying to pay. Part of that invoice was for an old operator, and part of the invoice was for the new operator. And CMS actually went ahead and passed them on appeal because it was out of their control. They could see that they had emailed them at least once a month trying to pay the bill. And they just couldn't get the vendor to work with them so they could get it paid. So know that and one of the things that they look at is when was it paid. If you get your Myers and Stauffer's audit today and you pay that contract invoice, they're probably not going to accept that. I feel like they're going to be moving to by the deadline that your agency invoice has to be paid. Just like they moved to your census has to be corrected by the deadline date of submitting your data. I think they're going to do that as well with the contract and agency. It seems like they're moving in that direction. So I just wanted to bring that to your attention as well. And then for your exempt staff, I do have a slide just for that. Reported hours must match your payroll records, no exceptions. So if for your salary people, it auto punches them in for Monday through Friday for 8 hours, right? And you're reporting 8 hours. We cannot, your pay stub and your timesheet has to match what you submit. So in your policy, it should state that your DON or whoever, their regular working hours are from 8 to 4:30 or 7 to 3:30 or whatever that looks like. And if there is a change in that schedule, that HR is being notified in some way. So if you're a DON and you're taking off at noon because you got a doctor's appointment or whatever, making sure that we're only claiming the hours that you're in the building performing your duties is important. But also it's important that if your DON or an exempt nurse works on the weekend and they take off, say Monday because they worked on Sunday, making sure that you move those hours from Monday to Sunday. If not, then you won't pass that audit. Okay? You'll have error on both days. You'll have an error on the one day for having 8 hours that you shouldn't have. Both days you'll have 16 hours of error. You see where I'm going with this? And then only actual hours work may be reported, PTO, training time, and meal breaks. And so I have a lot of questions on training time. So before we get to those questions, I just want to clarify. It is required that during our initial onboarding and orientation, HIPAA, abuse and neglect, there's several different trainings that our employees are not allowed to be able to be available for direct patient care. That's 3 to 6 hours depending how long your trainings are. But that training part, they're not allowed to be available for direct patient care. So you really need to have something in your system that will exclude that orientation time. And then all of your other training time, depending on your policy and what you're training on, if you have it in your system and in your policy that they're available for direct patient care, then you can claim that time. So for instance, if you hire a new LPN or RN or CNA, and they come in and they do their 4 hours of orientation, which we cannot claim for PBJ purposes, but then they have a preceptor that they're following in the hall, and they're also doing some direct patient care. If you have in your policy that they're available for direct patient care, then that 2 weeks that they're in that orientation, you're able to claim that time. Does anybody have any questions on that? Okay. And then, of course, we've already talked about meal breaks. Even though they're getting paid, we still can only claim, if they work an 8-hour shift, if you do from 7 to 3, then you're only able to claim 7.5 hours. So I highly recommend that your shifts be 8.5 hours so that you can deduct that 30-minute meal break and you still have 8 hours of RN coverage or 8 hours or whatever coverage that is. And then I just want to go over the basics of the job codes. So for your RN, the DON is a 5, your RN with admin duties is a 6, and your RN floor nurse is going to be a 7. So I get asked all the time, how do I know how to code these folks? It's real easy. Your DON always has to be an RN, and they're a 5. And your 7 is your RN floor nurses. And when I say your RN floor nurses, what I mean is that they have a MAR or TAR to support what they're doing. That means that they are either passing meds or doing treatments. All other RNs would fall under that RN with admin duties, infection control nurse, your ADON, MDS coordinators. All of those folks are going to fall under that RN with admin duties, admissions nurse, so on and so forth. Maybe you have a quality nurse, a nurse that does teaching and training. Those folks are going to fall under a 6. And the way CMS in their questions and answers have said, they expect us to help each other, right? And so you wouldn't change someone every time they did, one task different from what they normally do. So the way that CMS regulation states is that if their job duties completely change for more than half of the day. So it's expected for us to help each other. Don't burden yourself with changing coding 4 times in one day. Okay, I do see that with my new customers where they may have someone coded as a CNA and a med tech throughout the day. They've changed the coding 3 or 4 times. That is too much of a burden to providers, and that's not an expectation of CMS. And then your LPN, it's the same thing. Your floor nurses are the ones that have the MAR and the TAR to support, and everybody else would fall under that LPN with admin duties, whether it's infection control nurse, MDS coordinator, so on and so forth. They would fall under that. And then your nurses aides, I'm going to start with the 11. Once they've completed their book work in the CNA program, then we can code them to an 11 until they take their test. Okay, so they have 12 weeks to take their test, and until they take that test, if they pass it, then they change to a 10. If they fail, then you're going to have to move them to a 40 other service worker if they're working as a hospitality aide or something like that. And then once they're a CNA, a 10, then they may change because they went back to school and they got some more training and now they're certified medication aide or technician, then they would move to the 12. So there's sometimes, that moves. One of the things that I've been seeing is that Myers and Stauffer's is looking at when people get their license. Okay, so just know that they're also looking at licensing, so you're going to want to make sure that this is accurate. So it may be in the middle of the quarter that they got their CNA license. Make sure that you change it in the middle of the quarter. And I have seen with new customers where someone was working in housekeeping and they decided that they wanted to be a CNA 10 years ago and they're still coded as a 40 or a 39. And we never update that coding. And so we're not getting credit for those CNA hours. So make sure as people change and they get new license that you're updating those. I've also seen that a lot with LPNs when they go back and they get their RN degree, that we never change them from an LPN to an RN. I've seen it where it's 3, 4, 5 years that we've been coding them as an LPN when actually we could have gotten credit for an RN. So some of those pitfalls that I wanted to get you guys, some of that information.
That's great info, Jolene. I just want to share a question that just popped up in the chat too. And please jump in, Sherry, if I'm not understanding this right. So it sounds like she's asking if the RN admin does over half the shift as a floor nurse, should they code it to a 7?
Yes.
Thank you.
Yeah. Yes, you should. So if you have an 8-hour shift and it's more than 4 hours, you would change it. If you have a 12-hour shift and it's more than 6 hours, you would change it. Other than that, they don't expect us to make those changes. And then you're coding job titles correctly in PBJ. Weekly review is key. All hours must be coded to the correct CMS job code. Validate the job codes during your weekly time. And then at the end of the quarter, just do a final review. And then common mistakes is staff promoted to the DON, but the hours are still coded to the old title. So it looks like you don't have a DON. So your surveyors are when they walk through the door, they're ready to write you a tag for not having DON coverage. But then when you tell them, oh, I did have DON coverage, I just didn't change the coding, then you're at risk for inaccurate data, which is a different 16-point tag. Okay, one is a 16-point tag for not having the DON. The other is because you didn't code the DON accurately, you could have the other 16-point tag. So, you know, which is better? Neither. So make sure that you're updating those. Staff float across levels of care. I see this all the time. People clock in under assisted living and they're actually working in the SNF. So I highly recommend you doing a schedule audit monthly and for sure quarterly to make sure if you have assisted living, independent living, a hospital, connected and people are clocking in under the same system, and you just have a code like a 600 code or 800 code that identifies which side of the building they're on. Making sure that you audit that is vital, and also auditing your agency data as well, making sure you're not getting an AL agency that pulls over, because you can fail an audit that way too. I see more assisted livings failing their audits than any that's connected to assisted living than any other providers for that reason. And then the CMS expectation right here, that question that you guys had is right on the slide deck. If it's more than half the shift, then you would change it. If it's not, then you wouldn't. And then
A couple more questions came in, Jolene. I don't know if this is the right time for it. If the Dawn takes a vacation and a nurse is assigned to step in as the Dawn, do you need to make a PBJ adjustment?
yes. Yes, so that when your surveyors pull that information before they come in, they can see that you're covered, and that's not a survey pathway that they go down. Just remember, survey is probably the easiest thing that we do because it's an open book test. And we just need to make sure that we've studied it and we know where we're at. And I know that there's 1,000 DONs on here that thinks that what I just said is the craziest thing they've ever heard, but I truly do believe that. I had a group that was special focus and we got them off special focus in 9 months. And that's because we practice the test just like our football players practice 7 days a week, 360 days a year, it seems like. If we practice that same way, we're going to win the prize as well.
There's one more question too. How is the low weekend staffing measure calculated, and where can we see in advance if we will trigger for that? It's been a focus during many annual surveys.
So that one of the things, you know, the scrubber that I use, which is simple, is it will tell you what the lower 20th percentile. So it's based on the lower, if you trigger for the lowest staffing in your state, it's based on state. So if you're in the bottom 20%, then you're going to trigger for low weekend staffing, which means that you could potentially have a low weekend staffing. You could have a off-hour survey on the weekend. And so what you need to know is what your state cut point is. And like the state of Arkansas, for example, is 3.4. I do not know what Maine's is. I can go out and look at that. Nate, can you take a look?
Yeah, I'll take a look at that.
Yeah, if I could just add to that, excuse me, it's Mo from Maine Healthcare. By triggering for that low weekend staffing does not mean that you'll receive a staffing deficiency. So just as a reminder of that to people.
Yeah, it doesn't mean that you will automatically get a tag, but what it does mean is it opens you up for the weekend survey pathway. So anytime you open yourself up to a survey pathway, you're opening yourself up to additional tags. So when they come in and they do their survey, they are mandated to go through a couple of survey pathways for sufficient staffing. If you trigger for a 1-star or a weekend, then they have to go down additional survey pathways. They ask additional questions to your residents and so on and so forth. So just know that piece of it. It doesn't automatically qualify you for a tag, but it does qualify you for a more stringent survey. So the likelihood of you getting a tag increases. So we don't want to chase that number because there's always going to be people in that bottom 20%. And I think that's where Mo was going with this. There's always going to be people in the lower 20%. Knowing you're in the lower 20%, going down that survey pathway yourself, identifying your risk. If you have any risk, qualifying those risks and getting in front of anything that you find is key. So knowing where you stand is important so that you can be prepared. I do not recommend chasing to not be in that lower 20%. doesn't make any sense. Staff appropriately based on your patient's clinical needs. Don't chase an arbitrary number, is my thought on that. Nate, do you have the number?
Yeah, looks like so in the simple product, we look at the 22nd percentile to kind of give some leeway because we have to compare the full country, the full state data set. So 3.383 or 3.384 is the cut point for Maine for the last available data. And again, that's your adjusted nursing. So that's a case mix index adjusted value, but it's for the weekend staffing. So 3.384.
Perfect, thank you. And then we, maintain your PBJ checklist. You're just going to want to make sure that you're looking at update your time entries, confirm your nursing admin hours, make sure that if someone misses a shift that you're getting that covered if you need that for your star rating, and of course for your clinical care. And then weekly verify your payroll, enter any missing agency. On a monthly basis, enter that your medical director, pharmacy, dietitian, all your contract staff, upload your therapy hours if they're contract and they're not in your regular payroll. And then this says submit to the key system. That's changed to iKeys. I need to change that. You don't have to submit monthly. Most of my customers, what we do is we just upload on a monthly basis, do our scrub, find out where our risks are, increase our staffing if we need to, if we're going for a certain star rating, so on and so forth. And then we submit at the end of the quarter. And then the different PBJ Casper reports, I have these listed up here. I want to make sure that I'm not behind. So for your PBJ Casper reports, make sure that you give yourself enough time once you upload your data in order to be able to pull these reports so that you can see. Now, what I use to scrub mine does this already. It mimics the Casper reports, so I'm able to see this in real time, so I don't have to actually pull the reports. But for the folks that don't have a scrubber that does this for you, be sure to pull these reports and make sure that your data is accurate. And make sure that you have your final validation report. Some of the states I've been seeing that they're requesting to look at the last 18 months, which would be the last 6 quarters. So having those readily available is important. Now we're going to get into the methodology. I think most people already know this piece. So the case mix adjusted total nursing hours is your 5 through 12, and that's encompasses the whole week, not just the weekend. So that is what is from a value-based purchasing, from a national perspective, that is one of the measures that they're looking at. I'm not going to get into that, but I highlighted those in red just so that you would know. And then your case mix adjusted RN, which is 7 days. So as you can see on my slides, that your RN is in both 1 and 2. So there's 100 points in each one of these. So just know that your RN is more heavily weighted than anyone else because they're in both of these that are worth 100 points each. And then your weekend staffing is only worth 50 points. And that is your RN, LPN, and aides, and that's your 5 through 12 as well. And then your total nursing turnover, the percentage of nursing staff that left the SNF over a 12-month period, that includes PBJ job codes 5 through 12, which is also your RNs. And then the 5 is your RN turnover, which is the 5, 6, and 7. So as you can see, when an RN leaves, it's like getting punched twice because it's going to hit you in your total nursing turnover and in your RN turnover. And then your administrator, which is the number of administrators that have left in a 12-month period. And that is going to be, after you get 30 points there, and after one person leaves, that deducts down to 25 points, and then it goes down to 15 points. So every time an administrator leaves, it can hurt you as well. And here are the points that you can see those. Now, I will tell you, everybody in the country, since PBJ is now connected to value-based purchasing, and it's also part of managed care and HUD loans and just all kinds of things that PBJ is part of. A lot of litigators look at your staffing in litigation. So all of these things are really, really, really important, and staffing touches a lot of areas that we do. So just know that if you want to be a 2-star and you're doing prediction, make sure that you're not just at 155 points. Because if you're just at 155 points, everybody in the country is trying to increase, and it takes the national data into consideration. And that's something that no one can predict what your peers are going to be doing, because we don't have access to the other 14,000 whatever facilities to be able to see that. If I was doing a prediction, I would be wanting to predict at 165 or 170 if it was going to hurt me financially, or if that star I had to have, I wouldn't be okay with just 155. It's a 50-50 shot that you'll be a 2-star. So I just wanted everyone to know that. Same thing if you're looking for a 3-star. Let's just say you have a managed care contract that requires that your staffing be a 3-star. Make sure that you're going at least 10 points above the cut point to feel confident. And if you really need it, I'd go 15 points. Okay? Because we just don't know what the nation's going to do. And a lot of our data, the national data, is going to have some major changes. States like Ohio and Texas and some of these larger states that have, 1,000 SNFs, they're changing from PDPM, from the RUG 4, the RUG 3 to PDPM nursing for their case mix. So they're going to be driving that. So the national case mix is going to have some major changes in it in the next 6 months. Because of these 2 large states have just changed. So know that it's going to have a big influence on us nationally, because their behavior is going to change big time. Okay? Anytime you put dollars with anything, behavior changes. And so those 2 states, they have over 2,000 facilities out of 14. It's going to make a big impact on our PBJ data. And now I'm going to turn it over to Nate so that he can his part.
We'll go through a few more kind of data points here. Amanda, I know we're getting close to our time, so just cut me off if we need to go to somewhere else, but we'll try to kind of go through this. So thanks, Jolene, for all that we talked about. We just want to touch a little bit on the employee ID. The employee ID is a really critical piece that every shift that is sent to CMS in the PBJ file is attached to an employee ID. And then CMS has graciously also volunteered to calculate our turnover for us, as Jolene's talked about here. So they use that employee ID to track it over multiple quarters to see what shifts are in there. And we'll talk about some more turnover calculations here in just a couple of slides. But the employee ID is a really important basic piece of the data set that is important to remember for PBJ. Next slide, please. Well, there we go. And so it's actually kind of an important piece for having a solid PBJ foundation too, especially for turnover calculations. You're going to want to keep your same employee ID for every quarter. If you have the same employee there, same individual, keep that same employee ID over 1 quarter to the next for all time, so CMS can see that. If something changes and you have a change in your software and those employee IDs do change, there's something called an employee ID linking file that you can send to CMS that basically says, hey, CMS, this employee ID in our system, this is the same person as this other employee ID. And so it's a really basic file that you can send to let CMS know that. It's actually really important to do that because they're calculating this turnover for us. And so linking those together is really helpful. And then as Jolene mentioned a couple of times too, keep an eye on those agency contract employees, because even though they're not maybe direct employees of your nursing home, sending their file to CMS will have an employee ID attached to them. And sometimes we see that those employee IDs get changed from quarter to quarter based on the data that comes to from the agency company. So keep that in mind as well. We can go to the next slide when you're ready. So here is a brief kind of explanation of turnover calculation. I know turnover has been in the 5-star system now for a couple of years. But we wanted to touch it a little bit here and just talk about that for a few minutes. So for turnover, again, CMS is calculating this for us. When PBJ first came out, they asked us to include hire and termination dates, but they've since taken over and said, no, we'll calculate when the turnover happens. And so they're looking at what they call a gap in days work, kind of looking at these turnover, these employment spells. And so it's basically the number of your eligible employment spells based on those employee IDs. And then they look at anyone who takes a gap. So the perfect time for a new slide here. 90-day gap is what they're looking at. Any employees that work 120 hours, a minimum of 120 hours over any 3-month period within a certain time frame, they are eligible to be included in this calculation. And then if any of those eligible employees then go 90 days with 0 shifts worked, that then triggers a turnover calculation for CMS. Okay, so that's how they're tracking that. They are looking at 6 quarters of data going back to currently, right now, they're going back all the way to October 2023 to see those eligible employment spells. And then they're looking from January 2024 to December 2024 to see any employees that then went 90 days without a shift recorded. And I'll just mention this too, for those 90 days of no shifts recorded, that can be for any reason. That can be for extended medical leave, for family medical leave. It can be for anything like that being deployed overseas. CMS doesn't really care the reason for that. The idea is if they leave the facility for 90 days, they will become a turnover, even if they return after the fact. So keep that in mind too as you're keeping an eye on your staff and your employee IDs. So here's that employee ID linking we mentioned a few slides back. This is a way to let CMS know that 2 employee IDs really belong to the same individual. And the good news is it can go back over time. So if you have any kind of change in your IDs in the last 2 years, it's a good idea to send that, because as we just saw, CMS is looking back 1.5 years at your data. Let's see. Yes, CMS has also let us know that they calculate those linking IDs at the deadline of the submission. So at the submission deadline, they kind of freeze everything and they calculate all these turnover calculations. They look at any linking forms that have been sent. So if you're in a situation where you need to let CMS know that you need to link a few IDs, whether it's a handful or if it's most of your employees, make sure to do that at the submission deadline with your file as well. I think we have one more slide on this as well. Oh, one more back if you don't mind, Jolene, sorry. A couple of things to keep in mind just for validation purposes. The employee ID linking form is a pretty unique validation that CMS has. You have to submit it for the current quarter. So whatever quarter you're currently in. So right now we're in Q4 of 2024, technically in August here for the PBJ quarter. You have to select that quarter to send it to CMS, but it applies historically to previous quarters. And then if you do have new employee IDs, make sure CMS already has those new employee IDs in their system with the PBJ file submission so that they can see them in the system and link them to what the old employee ID would be as well. All right, next slide, please. Yeah, so I don't want to preach too much, but here's kind of some turnover measure success. Submitting your data on time every time is really one of the best things we can do, and one of the most important things to keep our turnover measures down. CMS has decided to be super punitive and give you the lowest turnover scores as possible if you are missing data in the last 1.5 years, or if you had any inaccurate data in the last 1.5 years. So keeping that really tight is good. Making sure you're having a way to check your data before you send it to CMS is also critical. And just like Jolene mentioned a few times, we want to be able to see what we have before we send it to CMS. Those payroll files are not always accurate. Maybe there's a change in employee ID, which would cause artificial turnover for you. I want to take a look at that, make sure everything is in there, make sure you're not missing any of those hours that you need to have. And then all that kind of ties into this trying to avoid 1.5 years of penalties for lowest possible turnover scores because of bad data. So with that, we can go to our next slide.
Okay. Amanda,
Yes.
we're at 6:21 my time. Do you want me to pause here, or do you want to ask questions? How do you want to?
Fortunately for us, we have had a chance to get some really great questions from the group in. How about if maybe just like 2 more minutes and then we'll wrap? Does that sound good?
Yep, that sounds perfect. Getting prepared for your PBJ audit. So everything that I just went over is going to help you get prepared for an audit because you're going to be in compliance all the time. So that it won't take me long to go through this. So first you'll get whoever is your PAYCOS person, registered as your PAYCOS person, will get an email from CMS, and then you will also get a certified letter. So if you get that from whoever is your PAYCOS person for your facility, then you really have a lot more time to get these submitted. So I highly recommend finding out who that person is and letting them know, hey, send that to me. And then what I tell my customers is wait till you get it in the mail and then do your registration. And then that gives us basically 14 days instead of 7 days to gather our data. So that's just a strategy I wanted to share. And then attachment A is just a sample list of the employees being reviewed. Attachment D is your provider survey. I'm going to provide Amanda with an example of that. Nate has that. If you don't mind dropping that into the chat for everybody here, and as well as the Excel form. And then your payroll records, your time punches, which that's going to show the time in and times out, your invoices for contract employees, time cards, and proof of payment, like I said, and then your employee handbook. Please don't send your entire employee handbook. I had one customer that did that. They passed their staffing audit, but there was something found in their employee handbook that got them a referral to OIG that was non-related. So never give the government any more than what they ask for. It's just not a good idea. And I also recommend having anything in your handbook looked at by an attorney before you publish it. That's just an extra nugget there. Now, this is what the letter looks like right here. This is one that's dated August 19th, and it's the latest one that I received. This particular group got 2 on the same day, and they weren't for any reason. They didn't trigger for any reason. And if you trigger, if at the end of the census questions, if they have another question, that you triggered for it versus that you just needed to be audited because you're in, they got to do a certain percentage. Okay. And then here is the attachment A. So that just has the employee IDs. You have to put the staff name, and then if they had a different ID, you need to let them know that. And so as you can see, the DON is in here. I've only had 1 or 2 where the DON wasn't pulled. Be sure to make sure your DON hours are always accurate. And then they try to pull 1 other exempt employee, nursing employee as well. And if you have agency, they try to pull 1 or 2 agency. This particular group doesn't use agency at all, so that none of those folks were pulled, but just so you know that. And then you're going to have the Excel spreadsheet that he's just dropped into the chat. You're going to fill that out, and then once you fill that out, you email it to this little CMS PBJ access to that email, and then you should have access usually by the end of the day, and then that's where you upload your data. So I just wanted, it's really, really super simple and easy. And if some of you guys don't have the Excel and you are getting it in the mail and it's really hard to scan in and whatnot, I've given you guys that to be used for anybody that gets a Myers and Stauffer's audit that's on this call. It makes it easier.
And just like usual, all of these resources will be sent out to you along with the slides, the recording, Jolene's and Nate's bios, everything that you normally get. We have maybe just 1 or 2 more minutes. If there were any questions that were burning that you didn't get to drop in the chat or ask yet.
I had a question. Nate, you did answer me in the chat, and I appreciate that. Thank you. I still just want to make sure I'm understanding that 120-hour rule. So is that what is that typical time period within the denominator period? You said of the slide you just showed. That's
And 120
seems
days.
like a really big period if I'm looking at it right, like over 6 months. Am I interpreting that right or no?
What were you thinking, Jolene, there? Sorry.
Okay, so let me make sure that the question that you're asking, that I have it right. So in order to qualify, you have to have 120 hours in a 90-day period.
Okay.
So it doesn't matter when that 120 hours happens. It could be 5 hours here, 100 hours this week. You know what I mean? Like it could be, but if they get 120 hours in that 90-day period, then that's how it's going to be. I tell a lot of folks with RNs, when you hire an RN and they come in and you know they're not going to work out, I would cut bait before 120 hours because they're going to be on your data for 6 months. I mean, for 6 quarters. And that's not,
Okay, that makes okay.
you see what I'm
And-
saying? And a lot of folks have it set up to where we have a 90-day grace period, you know, to figure out if they're going to work with us and we're going to work with them. And I tell folks, for your RNs, I'd be looking at them at 100 hours. Is this person going to work out? If they're not, I wouldn't have them back in my building because they're going to hurt you in both your RN turnover and your total nursing turnover for 6 quarters.
Okay, and if we have like agency staff that we use, if we only use them in a 90-day period for like fewer than 120 hours, they wouldn't hit our turnover.
No, but then also, let's just say that you have that agency person and they do qualify, or anybody, and they do qualify. Then that next quarter, as long as they worked 1 shift, they wouldn't hit your turnover. And then after so many quarters, they would fall off because there wouldn't be a qualifying quarter there. And a lot of folks call that phase out. And I have a lot of people that have phased out agency in that manner in order for their turnover not to just go into the dumpster.
So I
Okay.
see
Great, thank
we
you.
have
That makes more sense. Thank you.
we have about 2 minutes left. And
Any
in
other
case you guys aren't aware, Simple offers free webinars very regularly and gets into the nitty gritty of this. So if you're not on that distribution list, I recommend that you sign up. Like I said, it's free webinars and always good information. I am going to put the slide up now with the QR code. Let's see. Can you guys see that? Okay. Thank you so much for joining. I just want to make sure that I respect your time and that we wrap up on time. If you could complete this brief survey, it does help us gauge what's going well and what we could improve, also what you want to see more of in the future. If you prefer a link, Karen will drop that link into the chat if you don't have the capacity to do the QR code. After this call, any of these other questions related to QueST, you're welcome to send those to oads.nivquality@maine.gov. Today's recording and slides will be posted on the Rate Reform website, which Karen will also drop into the chat, also to the SharePoint site. If you haven't accessed that SharePoint, we encourage you to do so. Every old recording is there. Very neat. You don't have to save all of those emails. You can also request the chat log and attendance list if you'd like it. If you need us to send you a new invitation to that SharePoint, just let us know by messaging the inbox. As always, we will send all these materials out via email, including everything that Jolene and Nate shared today. So I will leave that slide up for just a few more minutes while we are closing out. But otherwise, we are wrapped, and I really appreciate your time and expertise, Jolene and Nate. You guys were fabulous. We had a lot of really great questions from the group, so thank you. And with that, we'll wrap it and have a great day. Thank you.
Thank you, everyone. Appreciate you for inviting me.
Thank you so much.